Okay, the fourth lecture in pain station in the critical care stations in MRCS part B OSCE. Okay. Well, one question remaining about paracetamol here, and he's going to ask you about the management of paracetamol toxicity. Okay, so this is a question that you want to answer. There are many steps actually. Number one, you are going to do something called gastric decontamination, and you can say also gastric lavage. Okay, gastric lavage, and this usually done in a period of less or equal 1 hour. Okay, 1 hour. Fine. The next thing that you are going to do, or you can do, is administration of something called activated charcoal. Okay, charcoal, and this also is usually given in a range of 30 minutes to 2 hours. Okay, well, and this is ingested. Actually, you give it by mouth, and it has a positive effect. Okay, there is an antidote called acetylcysteine. Okay, antidote, and it is called acetylcysteine. Okay. And acetylcysteine antidote usually helps to replenish or to return the production of glutathione, and in this way the chelation and the removal of the NAPK will be better. Okay, so if all these steps did not work, you did a lavage, you gave charcoal, you gave the acetylcysteine as an antidote, and liver failure ensues, it happened already, then you have no option other than transplantation, liver transplantation. Okay, so these are the ways by which you are going to treat the patient from toxicity. Okay, he may ask you about the dose of paracetamol. Okay, and the normal dose for the patient, for the adult patient, okay, should be less than 4 grams per day. But if he asks you about the minimum toxic dose, it starts from 7.5 to 10 grams per day. Okay, so this is a minimally toxic. You start to have toxicity and liver damage. Okay, this is for adults. Fine. For the children, okay, the minimal toxic dose is 150 to 200 milligram per kg. Okay, 200 is usually for the children who are 1 year and above, 1 to 6 years, and 150 is for those who are less than 1 year. Okay, well, these are all the questions that will show up for you about paracetamol. Now he is going to ask you the next question: why will you give non-steroidal anti-inflammatory drugs? And in this station here, for this patient in the scenario, you are going to say no. Okay, he is going to ask you why no, because this is in the WHO letter, right? So why you are not going to give non-steroidals? We are not going to give non-steroidals because the non-steroidals cause coagulopathy, and he has a wound already, he has an operation. Okay, so how he will ask you, how does it cause coagulopathy? And you are going to tell him that the non-steroidal anti-inflammatory drugs inhibit the thromboxane A. Okay, and this thromboxane A is produced by the platelets and it causes aggregation of the platelets to primarily form the platelet plug. Okay, so if this is inhibited, bleeding may occur. So you are not going to give non-steroidal anti-inflammatory drugs. He's going to ask you what are the side effects of non-steroidal anti-inflammatory drugs in general. Okay, and you are going to divide them into categories as usual. Okay, first of them that we have mentioned here is coagulopathy, and this is your main cause that you are not going to give this to this patient in this scenario. Okay, number two, they cause bronchospasm also, and bronchospasm is a complication that you are not you will not favor in a post-operative patient. Okay, and how bronchospasm occurs, because this will inhibit the COX pathway. Okay, due to this, the arachidonic acid will be metabolized to leukotriene due to this, and this will lead, leukotrienes will lead to bronchospasm. Okay, to spasm, bronchospasm. Okay, so this in case that you need to know the mechanism. Okay, there are some complications from non-steroidal anti-inflammatory drugs on the GIT also, and these are known for everybody. They cause dyspepsia, they cause gastritis, they cause peptic ulceration. Okay, and in addition to that, they have direct effect in acid. They increase the acid production in the stomach, and they reduce the production of bicarb in the parietal cells or in the mucosa. Okay, so these are the side effects of non-steroidals in general. So he's going to ask you, what are you going to do now? You are going to tell him that I may go to what is the next step here? Okay, you will not give non-steroidals. What are you going to do? So you are going to tell him that I may give codeine. Okay, and codeine, he's going to ask you, do you think that codeine is bad? And you are going to tell him, yes, it is bad. He's going to ask you why. Okay, and the why question here, you want to know the answer for the why question. Okay, so what is the problem of codeine in general? Okay, fine. The problem of codeine, it is bad because you want to know first that you want to know that the codeine first of all is metabolized to morphine. Okay, and the analgesic effect of codeine comes from this. So there is an enzyme in the P450 system, and this enzyme is called CYP2D6. CYP2D6. This changes codeine and forms morphine from it. Okay, so there is about 10% of population, they do not have this enzyme, and in this way they will not get the analgesic effect of codeine. This is the first point here. The second point that shows this morphine is bad is this codeine is bad for the patient because it has many side effects, and it causes all the side effects that you may know in your life. It causes drowsiness, it causes constipation, it causes itching, it causes nausea, vomiting, dry mouth, meiosis, hypotension, urinary retention, euphoria, dysphoria, coughing, sometimes anaphylaxis, seizures. It can cause acute pancreatitis. It can cause respiratory depression. All these, too many complications and too many side effects for it. Okay, can occur from codeine. Okay, the bad news are that if for those 10% we mentioned before who do not have the enzyme CYP2D6 that change the codeine into morphine, they will complain of all the side effects, but they will not get the analgesic effect, and that is not good. Okay, so this is your answer for the examiner. It is transferred or changed to morphine by this enzyme, and it has many side effects, and you are going to mention them: drowsiness, constipation, itching, nausea, vomiting, dry mouth, meiosis, orthostatic hypotension, urinary retention, dysphoria, euphoria, coughing, sometimes anaphylaxis, seizures, acute pancreatitis, and respiratory depression. Okay, these are the common complications for this. So we are going to ask you now, what is the next? What are you going to go now? This patient has still pain, okay, and you want to manage his pain. What is your plan here? And you are going to tell that I'm going to give morphine. Okay, so he's going to ask you what is the normal dose of morphine, and it is 0.5 to 2 mg per bolus. Okay, 0.5 to 2 milligram per bolus. Okay, this is the normal dose. So the ways to administer morphine: number one, directly. Okay, and number two, through something called PCA. Okay, and in this point here, he's going to ask you, let us talk about PCA. Okay, and in the PCA also the dose is same. It's 0.5 to 2 milligram per bolus, but he's going to discuss the PCA with you in some details. Okay, well, what do you want to say about PCA, and what will he ask you about PCA? Okay, first of all, he's going to ask you about the definition. What is the definition of PCA? And you are going to tell the patient that it's an electronically controlled infusion syringe pump, okay, that's connected IV intravenously. I'm sorry, not 5, IV. Okay, and it allows, or to allow, the administration. It is self-administration actually. Of morphine. Okay, and as I told you that the bolus of morphine is usually 0.5 to 2 milligram to relieve the pain. Okay, so it's an electronically controlled infusion syringe pump connected, okay, IV, to allow self-administration of morphine. This is the definition. Okay, so he's going to ask you now about the what are the benefits of PCA, and what are the complications or problems or adverse effects of or problems of PCA. Okay, so you are going to start with the benefits. Okay, number one, the benefits. Okay, so first of all, number one, it is faster to respond for pain, right? Number 2, it is safe. Why it is safe? Because number 1, or A here, okay, there is a one-way valve in that thing. One-way valve. Okay. B, there is something called a lockout time. And lockout time means that if he felt pain, he pressed this appliance once and he tried to push it again, he cannot. There is a time that should pass before he can be able to press it again. And also the dose is controlled. So you control the dose and you control the frequency, and you keep it with the patient. It is inside the patient, so he can press it at any time. So when he feels pain, he can press it. Okay, so these are good things. Okay, so it is safe. Fine. It will reduce the nursing input. You do not need to shout every time to take analgesia for the nurses who are busy all the time. Okay. I think that these are the most common things. So the medication errors are less. No medication errors, because the medicine is known inside the pump, and there is no problem. Okay, so these are the benefits. Now we are going to go to the problems. What are the problems? Okay, so first of all, to use the PCA, the patient should be oriented, should be awake or mentally well. Okay, number 2, this PCA can break. Number 3, it may go out of battery, also out of battery. Okay, so it may stop at any time or run out of battery. Morphine, as you know, that it causes sleep disturbance. So, and the PCA itself in its place causes sleep disturbance. Okay. Other problem, as I told you, that it is patient should be oriented, so you cannot use it with the handicapped, right? It limits the patient's mobility. Okay, patient is not free to move as he wishes. Okay, and then you want to add the complications of morphine itself, right? And to add respiratory depression, sedation, nausea, vomiting, itching, urinary retention, and constipation. Okay, so these are the problems with the PC.